I'm extremely thankful to Professor Martin, Dr. Sonal, and Dr. Jason for giving me this opportunity. I would be speaking on the basic steps of strabismus examination. The questions to be answered at the end of examination are whether the patient that we are dealing with actually has strabismus. If it is strabismus, then what kind of strabismus we are dealing with. We must have an idea of the refraction, visual acuity, and the binocularity of the patient at the end of the examinations. And we should also have an idea about whether we would be able to manage the patient ourselves or we need to refer the patient to a higher center for appropriate management. I would not be covering specific questions related to surgical planning in this presentation. The examination of the patient can be broadly divided into three groups. One would be the assessment of vision and refraction. Second would be the motor examination and the sensory examination. And as can be seen that not many equipments are required for the basic examination in strabismus. So all attempts must be made to have an assessment of the visual acuity of the child. A small child may require instruments like optokinetic drum or a preferential looking chart. And slightly older children would be better off once they are explained the E chart. Eventually the school children would cooperate on the Snellen chart. Refraction must be performed under adequate cycloplegia. The choice of the cycloplegic agent would depend on the age of the child and the race of the child. Observing the pupillary reflex is a very useful tool, wherein an asymmetrical reflex, as can be seen in the lower photograph, or an unhealthy reflex gives us significant information about the patient. It is also useful to observe the deviation under cycloplegia, as when the patient is under cycloplegia, the accommodative effort is gone. This is the time to perform retina examination and assess the fixation of the patient. And should amblyopia be suspected, attempt must be made to rule out all the other causes of poor vision and also to quantify amblyopia. Coming on to the motor examination, all three components of the anomalous head posture, the face turn, the head rotation, and the chin elevation or depression should be noted. Hirschberg's test gives us an idea of the type of deviation and also the amount of deviation, which is eventually confirmed by the cover test and the cover-uncover test, which I would be covering in the next slide. There's a small video to clarify it. And the deviation is confirmed with the prism and cover test. An important point to note is that the child should be fixing at a target which could be an accommodative target mounted onto the spectacle frame of the examiner, as can be seen in the photograph. Subjective tests in patients who complain of diplopia, like the Hess charting, may be performed, and it is important to eliminate the head posture by performing these tests. A note must be made of the limitation in ocular movements. Firstly, the versions are texted, and once the motility limitation is noted on versions, it is confirmed on ductions, and finally, the vergences should be tested to complete the motor examination. This is a small video to demonstrate the cover test. The examiner first covers the fixing eye to elicit fixation movement in the non-fixing eye, without and with the glasses. To measure the deviation, prisms are then placed over the fixing eye, and they are gradually increased till no movement is noted. This gives us an idea of the amount of deviation. In the sensory examination, diplopia chart is a very useful tool and should be performed in patients of incomitant deviations. Worth 4-dot-test gives us an idea of the binocularity of the patient, and the actual quantification of stereopsis is done on tests like the Randot stereogram. The beginners should watch out for gaze incompetence, where the deviation is increasing in up gaze in this patient, and there is an obvious inferior oblique overaction. They should be wary of the motility limitations, which could often be missed as the primary position, the patient is almost straight. They should be wary of the palpebral fissure abnormalities and the motility limitations. And again, very large deviations and cyclic deviations are best handled by the experts. Finally, one needs to analyze and re-examine the findings of the examination, and the complete examination may take 2 to 3 visits. It is obvious that the strabismus examination should be performed with proper refractive correction in place. And if we are giving the refractive correction on the first or the second visit, the complete examination would be performed on the subsequent visits. It is useful to perform the sensory examination before the motor examination, because there is often disruption of fusion when you are performing the motor examination. Cover test and the cover-uncover test are the basic foundations, and all practitioners who intend to deal with strabismus patient should be confident about these 2 tests. And the beginners should be watchful for gaze incompetence and motility limitations. The photographs of this presentation were from my textbook on strabismus, and I end with a big thank you. I would be happy to take up any questions if there are.